and he's from the Urology Center of Orange County, and he's going to be speaking about understanding prostate anatomy and HoLEP, key landmarks for safe and effective enucleation.
So I'll give a quick background relevant to the talk. I was born in Dr. El Hilali's hometown and trained at UT Southwestern with John McConnell and a Klaus Rohrborn BPH heavy program, and then joined the staff at Cleveland Clinic, robotic, minimally invasive, and advanced laparoscopy heavy training program. And I'm the one least experienced with HoLEP. And This is my story with HoLEP. I've always heard that it's very intimidating to learn growing up in the urology ranks. It's at least 100 cases. Who wants 100 cases to just begin proficiency in a case? I'll do everything else. And I did. I did almost every BPH procedure except HoLEP or ThoLEP. And I went on into the ablative lasers with holmium, thulium, green lights, evolve, all of them. And then went on into minimizing the invasiveness of a robotic single port or robotic transvesical prostatectomy into single port transvesical prostatectomy. And we encountered a lot of initial high complication rates. And then finally, one of my mentors said, I think it's time for you to learn HoLEP. So I did. And here is my experience with learning HoLEP or adopting it. And I think one of the talks in this session was about adopting it late into one's practice or career and transforming or transferring my knowledge in the adenoma anatomy with these single port or robotic transvesical and the open prostatectomies and the Millen prostatectomies and the lasers in seeing the adenoma with different angles and axial imaging. I found out that it does not necessarily need to be 100 cases just to gain familiarity with the procedure. And reflecting back to this topic was chosen for me. I did not choose to speak about HoLEP because certainly, as I mentioned, it's a procedure I'm least familiar with. But I was asked about the topic of anatomy relevant to HoLEP, and I thought, okay, I have to reflect back on my journey and how did I learn and transfer my knowledge of anatomy for the adenoma into making the HoLEP procedure applicable into my practice. I'm certainly more comfortable going into the HoLEP with single port robotics, and especially with big intravesical lobe or intravesical pathology, big diverticulum or a stone. And I started choosing my patients very carefully with the adenoma size and adenoma that I see clearly distinct on a transrectal ultrasound. And I went on and started cheating my way into the HoLEP and say, okay, I'm going to microenucleate. I'm not going to use the morcellator because I don't want to do a bladder biopsy like Dr. El Hilali would say. I want to just like cut it with the laser, with a side firing laser into a small pieces that I can flush out and it give me a readable pathology slides and allow me to gain comfort with the visibility in the process of lasering out chunks of prostate tissue. So the relevant anatomy, as we know, a lot of times, and when I speak to previously to the residents and students and the fellows and colleagues, all the time we ask, how big is the prostate? And there's usually one number answer, and I don't like that. They should be a lot more than just one number answer, because the one number usually refers to the total volume of the prostate, which has less relevance to a BPH procedure. I want to know the total prostate volume when I'm doing robotic radical prostatectomy. But for a BPH procedure, the prostate volume doesn't mean much. I want to know the transitional zone volume, and usually we should either get like a truss or an MRI and know the adenoma size. And for me, I want to know also all the dimensions, the width at the apex, what is the median lobe, what does the capsule look like? Is it a clear distinction where I know it's just gonna shell out easily? Are there stones around the transitional zone? What is the Doppler flow around the capsule? And I know if I goof and get through the capsule, how much bleeding, where should I be careful? All of those are very relevant information to transfer into the process, the procedure of learning and mastering the HoLEP. Obviously, the key landmarks with any BPH endoscopic procedure, the bladder neck, and with a median lobe behind it, usually the UOs. And it depends on every anatomy is different. The UOs could be very close, and you could get into them at the end of the lateral lobe dissection close to the bladder neck if you're not careful. Also the apex and the sphincter and the vero. And it's important to know that if you're afraid of the sphincter, you're gonna leave apical tissue. It's important to remember that the sphincter is few millimeters distal to the vero, and you just need to follow your eyes and follow the adenoma. Just follow the dotted lines. It's going to be the prostate is going to be shorter anteriorly, but the sphincter is clearly distinct. And you can always see it. It's puckering. It's a circular structure distal to the vero. Anatomy is important to any surgical procedure, but why does it matter? Why are we talking about it specifically into HoLEP? Because HoLEP is very intimidating and not a forgiving procedure. It's not, it's a very steep learning curve. As I mentioned, there's a big barrier to a lot of urologists learning it early into their careers. So it's fundamental to apply strict anatomical knowledge and principles to shorten the learning curve and increase the safety early on in the learning curve. The surgical capsule is very important to recognize for HoLEP, just like with any other, with a TURP. But with the HoLEP, it's a bit more challenging to recognize than with the TURP or with the green light vaporization or other procedures because the visibility is a bit different. And there's always, we've done a lot of the visibility with the HoLEP is a lot less than with almost any other BPH procedure. It's the inherent nature of it, and there's a lot of ways to optimize the visibility. The scopes, as mentioned in the previous talk, the angle of the lens, the diameter of the scopes, continuous flow, etc., and meticulous hemostasis, and using the proper laser wavelength, defocusing it, and the hemostatic settings. But nonetheless, it's important to develop an eye to what does the capsule look like compared to the adenoma tissue and maintaining that, because you can veer off and get into a different plane, especially in a multinodular adenoma, because the adenoma can do different shapes and forms. And a lot of times you find an aberrant nodule that fools you and you get in between those two nodules and it's not the true capsule. So it's very critical to stay with one plane, maintain visibility and pay attention, invest more time to do hemostasis as you go, as opposed to leaving it all towards the end. So the surgical capsule, maintaining it and staying in the same place is very critical and usually looks like a cobweb or a very delicate a cotton-like fiber tissue compared to an adenoma or solid white dense adenoma tissue. So there have been plenty of videos in this session in life surgery showing the enucleation process and what the adenoma and the capsule looks like. So for the interest of time, we will go quickly through these videos. But there are these videos where for different types of lasers, but it's important to note that my reference encompasses all lasers used for enucleation, including the thulium, the thulium YAG, the thulium fiber, and the holmium, traditional holmium, the MOSES technology. And I've tried them all, and everybody is comfortable with different technology that's available to them, and the experience is transferable. So it's important to recognize the capsule, the bladder neck, the vero, and the sphincter with any BPH procedure. And it was mentioned in the previous talk. I prefer the 30-degree lens. And obviously, almost everyone uses a continuous flow laser scope using a cannula or no cannula. Plane recognition is key, and it depends on color and texture distinction and remaining in the plane and following through with it, because if you leave it and you come back, it will look different. The capsule is white fibrous tissue, looks like cobweb or cotton fiber. And the adenoma is usually a yellowish tan or dense, solid, pale white tissue. Fundamental anatomy and mastering the anatomy of the prostate and recognizing that all prostates are the same, but all prostates are different. Just like anything in life, the prostate varies in how the apex looks, how wide it is, how anterior. A lot of times we say anterior fibromuscular stroma is just that, but a lot of times you see it's almost like a mirror image. You have a middle lobe anteriorly, complete glandular structure in the anterior fibromuscular stroma. Go argue with the prostate. This is not what it's supposed to be. So every prostate is different, and understanding that peculiar anatomy for the patient at hand is key to altering or modifying the technique and tailoring it and customizing it to that prostate at hand. Without this is not a technical or how to talk, and it was covered extensively throughout this session and yesterday. But the principle, the concept is modifying or anatomy-based technique adoption. This is one of the examples of how I choose my patients for HoLEPs or transvesical prostatectomies, prostates that are very broad, especially apically. I find out that in order for me to do the traditional 3-lobe technique, I have to torque too much to kind of follow the apex or peel the lateral lobe cleanly from the apex without leaving apical tissue, and that stretches the sphincter too much. And yes, it will recover, but it increases my early on 12-week stress incontinence rates and severity. So I find out if I don't have to torque that much apically at the sphincter, the patient may enjoy early return of full urinary continence. There we go. So the common mistakes to avoid is over or under dissection at the apex. If you're too afraid of hitting the sphincter, you're going to leave apical tissue, and depends on how much apical tissue you leave and the detrusor function, that could be detrimental. A lot of people would have a successful enucleation or TURP or prostate procedure, and they have apical tissue and they have retention on voiding trial. So it's important to follow and get the entire adenoma, especially for a HoLEP procedure where we expect you to get as much of the adenoma, if not all of the adenoma, as possible. Ureteral orifices could be injured initially with the middle lobe or during the end of the lateral lobe separation at the bladder neck in a retrograde, the traditional three-lobe technique. Capsular perforation is gonna reduce your visibility, and the problem is perfecting every step makes the next step easy. So if you perforate anywhere in the capsule, unfortunately, back to the unforgiving nature of the HoLEP is going to make things difficult. And all of the, yes, defocus and change into the coax setting, it's still going to be bloody. It's still going to be a poor visibility as if you compare to not getting into the capsule at all. So try not to get into the capsular perforation because those vessels, they're not gonna coag. You need to compress them. They're sinuses. And back to the point that was made earlier at the podium is using a bug bee versus a loop. I find out the loop is easier to control because you can compress as opposed to the soft nature of the bug bee. It does not give a robust compression and hemostasis, especially in heavier bleeding. The bug bee may be okay for majority 80% of the time, but there are some cases that compressing the vessel is necessary. Bladder perforation, usually knowing the bladder capacity and maintaining distension is key. And maintaining the distension usually relies on the dynamics of the suction irrigation, and the equipment is very finicky. The technology is way behind. I don't know, I don't do a lot of HoLEPs, but when I see people, I think the earlier talk, they were using a stores morcellator, which I've seen in Egypt, and I believe it's a lot superior, but I don't think it's available in the US yet. We usually have the piranha, the wolf morcellator. But I think the stores morcellator and the irrigation and the suction dynamics are a lot easier to deal with and less finicky than the wolf system. But nonetheless, it's important to pay very close attention to the flow and the circulators, the team around you, and the suction, because if you suction more than what's going in, the bladder is going to be less distended, and that's when you can combine that with poor visibility, you're going to have a bladder biopsy. So the anatomy is foundation and key to safe surgery anywhere, but particularly so and critical for HoLEP because it's a not forgiving, it's not an easy, it's an intimidating procedure. And veering off anatomical landmarks is going to have dire consequences throughout the case. No fundamental knowledge and applied anatomy to the procedure allows for safe procedure, great outcomes for patients, especially early on in the learning curve, and shortening the learning curve for adopting surgeons. Thank you for your attention.